Severity depends a lot on personal frame of reference. It depends on the age of the child, and we don't have any specific protocols or forms that are generally agreed upon among speech pathologists to designate mild, moderate, and severe. And when you think about it, a 2-year-old is expected to be intelligible about 50% of the time, and a 4-year-old about 75% of the time. So children at these two ages with similar sound and words systems, you would think the 4-year-old is more severely affected. And the expectations for the 2-year-old would be hopefully that they could improve to a point where it would be less severe by the time they're 4. So with that in mind, I tried to devise my own sort of idea of what's mild and moderate and severe, thinking very simplistically that severe would be a child who has a very limited number of sounds or syllable shapes, especially related to their age, and probably no fully intelligible words or phrases, or very few. Where at a moderate level, the child may be communicating verbally and have a few words and or phrases and a larger sound system, but is still not readily intelligible based on their age expectations. And they might have errors that still indicate motor difficulties, such as vowel distortions or inconsistency, in conjunction most likely with some phonological errors. A milder child we would expect to be pretty verbal, but maybe not as intelligible as expected for age, and again with some indications of motor impairment in addition to other errors. And we'd expect, though, longer and more complex words and sentences. So when you think about therapy changing, the therapy for a child who is more severe, if you think about the principles of motor learning, you would want more mass practice, you would want more frequent feedback, you would want more predictable sequence of practice, so probably blocked practice. You might introduce variable practice because we want to introduce prosody early in therapy, but maybe to a lesser degree for that severe child. And you'd have fewer targets because you want to get a lot of practice. As the child moves along the continuum, we're reducing cues, we're making things less predictable, so we're thinking about more distributed practice, and we're thinking about more random practice and less feedback, letting that child take more responsibility, and greater variability, and increasing the number of targets. And this is sort of a dance that's going on throughout therapy, from where you start to where you're finishing,